Welcome to this Step 3 review on eye complaints, brought to you by Roadmap to Residency. Eye questions look intimidating because the anatomy feels far from everything else you study, but they are among the most pattern-driven questions you will see. The test writer is not asking you to be an ophthalmologist. The test writer is asking whether you can tell a benign red eye from an eye that is about to lose vision, and whether you know what screening is due. Today, we break down exactly how those stems are built and how to attack them. Work these patterns alongside your question bank, because they are learned by doing, not by watching. Let us get started. Here is what we are going to cover. First, we will learn to sort any red eye vignette using 3 discriminators: pain, vision change, and pupil findings. Second, we will drill the sudden vision loss stems, the ones where the exam is testing whether you recognize an emergency and refer immediately. Third, we will handle the quiet screening questions about glaucoma and diabetic retinopathy, which look boring on purpose. Along the way, we will walk through practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to triage the red eye before you read a single answer choice. Every red eye stem hides 3 discriminators. Is there pain? Is vision affected? Is the pupil abnormal? Find those 3 first. If the answer to all 3 is reassuring, meaning no true pain, normal visual acuity, and a normal reactive pupil, then you are in benign territory. That is conjunctivitis, or a subconjunctival hemorrhage, or dry eye, and the correct answer will be conservative outpatient care with return precautions. The test writer will still put an urgent referral choice in front of you to see if you panic. Do not take it. Now, the moment even one of those 3 discriminators turns abnormal, the entire question changes, and that is what we cover next. Strategy 2 is learning the danger words. These phrases appear almost verbatim across eye vignettes, and each one is a signal. Deep aching pain, photophobia, halos around lights, a hazy or cloudy cornea, a fixed and mid-dilated pupil, a poorly reactive pupil, decreased visual acuity, and contact lens wear. Circle them the moment you see them. A single danger word flips the vignette out of the clinic and into same-day ophthalmology. If the stem says the patient sleeps in contact lenses and now has eye pain, you are looking at a corneal ulcer until proven otherwise. That patient needs urgent referral and a corneal scraping. That patient does not get a topical steroid and does not get an eye patch. Both are harm traps, and the exam plants them deliberately. Now let us handle sudden vision loss, where the emergent referrals live. The single most useful move is to ask whether the vision loss is painless or painful, because that question splits the entire differential in half. Sudden painless vision loss points toward retinal artery occlusion, retinal vein occlusion, retinal detachment, or vitreous hemorrhage. Sudden painful vision loss points toward acute angle-closure glaucoma, endophthalmitis, or severe keratitis. Ask about pain first and half the choices disappear. Then match the buzz phrase. A curtain coming down over the visual field with new floaters and flashes is retinal detachment. A pale retina with a cherry red spot is central retinal artery occlusion. A blood and thunder fundus is central retinal vein occlusion. A transient painless shade that resolves is amaurosis fugax, and that patient needs a carotid workup. Here is the rule that ties it together. When vision loss is sudden, the correct answer is almost always the fastest one. In suspected giant cell arteritis, you start high-dose steroids before the temporal artery biopsy. Doing the slow, reasonable-sounding thing is the trap. Let us work through our first practice question. A 68-year-old woman presents with several hours of severe right eye pain, blurred vision, and halos around lights. She has been vomiting. On examination, her eye is red, the cornea is cloudy, and the pupil is mid-dilated and reacts poorly to light. The eye feels firm to palpation. The question asks for the most appropriate next step in management. Before you choose, count the danger words. Read the 4 options carefully and pick your answer. Then we will walk through the reasoning together on the next slide. Let us break this down. First, spot the pattern. The danger words are stacked one after another: severe pain, halos around lights, blurred vision, a cloudy cornea, a mid-dilated pupil that reacts poorly, and a firm globe. Notice the vomiting. That detail is deliberate misdirection because a weaker student starts thinking about a gastrointestinal cause. This is acute angle-closure glaucoma. Next, apply the rule. Painful sudden vision loss with a firm eye is an emergency, and the correct answer is the fastest sight-preserving action. Finally, eliminate the wrong answers. Antibiotics with follow-up in 1 week treats an infection that is not there and wastes the window in which vision can be saved. Warm compresses and antihistamines belong to allergic conjunctivitis, which is itchy, bilateral, and painless. Steroid drops with an eye patch is the harm trap. You never put a steroid in an undiagnosed painful red eye, and you never patch it. The correct answer is immediate ophthalmology consultation and pressure-lowering therapy. Here is our second practice question, and this one is testing whether the danger words are automatic for you yet. A 22-year-old college student presents with 1 day of right eye pain, foreign body sensation, tearing, and light sensitivity. She sleeps in her soft contact lenses. Visual acuity in the right eye is reduced. On examination, the eye is red, there is a small white opacity on the cornea, and fluorescent staining shows an uptake defect. The question asks for the most appropriate next step in management. Pause on the contact lens detail. Read the options and commit to an answer. Then we will work through it together. Let us break it down. Scan for danger words first, and the STEM hands you 4 of them in a row. Contact lens wear, pain, reduced visual acuity, a corneal opacity with a staining defect. Anyone alone should slow you down. Together they are bacterial keratitis, a corneal ulcer, and it is vision-threatening. This is never a reassurance question. Now eliminate. Reassurance and artificial tears ignores a threatened cornea and reduced acuity, which is exactly the mistake the writer wants. Topical steroids suppress the local immune response and accelerate an infectious ulcer. That is a harm trap, and steroids in an undiagnosed red eye are almost never the answer on this exam. Patching traps organisms against the cornea and is contraindicated in contact lens-associated ulcers. The correct answer is urgent ophthalmology referral for corneal scraping and culture. Now let us switch to the screening stems, because they are built completely differently. A screening vignette hands you a well patient. No complaints. Normal vital signs. A normal examination. Nothing is wrong, and that is the point. The question is not asking you to diagnose. It is asking whether you know what preventive care is due right now. When the patient feels fine, stop hunting for a disease and start hunting for a gap in screening. As for content, for glaucoma, the exam expects a comprehensive, dilated eye examination by an eye care professional, with more concern in older adults, in patients of African ancestry, and in anyone with a family history. For diabetes, a dilated retinal examination is expected at diagnosis in type 2 disease, about 5 years after diagnosis in type 1 disease, and yearly after that. Confirm current intervals in a standard clinical reference rather than one edition of one book, because these get updated. Here is our third practice question, and it is a screening STEM in disguise. A 54-year-old man with type 2 diabetes for 8 years comes to the clinic for routine follow-up. He feels well and denies any visual complaints. His blood sugar control is at goal on metformin. He has never had an eye examination since he was diagnosed. His vital signs are normal and his examination is unremarkable. The question asks for the most appropriate next step in management. Notice how nothing is wrong with this patient. That is your clue. Read the options and choose, then we will walk it through. Let us break it down. First, symptoms are not the trigger. Diabetic retinopathy is silent until it is advanced, which is the entire reason a screening program exists. The fact that this man denies visual complaints tells you nothing reassuring. What matters is that he has had type 2 diabetes for 8 years and has never had a dilated retinal examination. He is overdue right now. Now the key distinction, and this is where the distractors live. Reassurance because he has no visual symptoms is wrong for the reason we just covered. Magnetic resonance imaging of the orbits is the overkill trap. It is expensive, and there is no examination finding to justify it. Measuring intraocular pressure alone is the do too little trap. Pressure screens for glaucoma and misses the retina, which is the organ at risk. Every wrong answer either does too much or does too little. Let me leave you with a decision tree you can run on any eye complaint in under 10 seconds. First question: is there pain? Is there reduced visual acuity, or is the pupil abnormal? Ask that before you read a single answer choice. If the answer to all three is no, you are in the benign lane, and the correct answer will be conservative outpatient care. If the answer to any is yes, you are in the danger lane, and every conservative-sounding choice has become a distractor. Second question, asked only in the danger lane. How fast must I move? Sort the remaining choices by speed and pick the fastest sight-preserving action. Same-day ophthalmology evaluation. Immediate pressure lowering. High-dose steroids before the temporal artery biopsy when you suspect giant cell arteritis. If a choice delays care in a threatened eye, cross it out. Reasonable-sounding delay is the single most reliable trap in this subject. That is your framework for eye complaints. 2 lanes, benign and danger, sorted by pain, vision, and pupil. Now go make it automatic. Drill eye vignettes in your question bank until the danger words jump off the screen at you. Reinforce the anatomy and pathology using the ophthalmology chapter of your primary review book, and confirm current screening intervals in a standard clinical reference rather than memorizing them from a single edition, because those intervals do get updated. Read every explanation, even for the questions you answered correctly. And visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If this video helped you, please like and subscribe for more board review content. Good luck on your exam, and we will see you in the next one.